Welcome everybody. My name is Vicky Hanna and I'm doing this unit for you. This is a core unit in the community scope. So this is CHCMHS001, Work with People with Mental Health Issues. Let's begin. I'll do acknowledgement to country and then I'll do an overview of what we're going to be covering. We're going to do 3 short sessions in blocks so that you can absorb the content. We're working in a non-clinical mental health space. This is to help you as a support worker. Everybody has mental health. We're going to have a look at some of those mental health issues. We're going to look at some mental illnesses. However, we do not diagnose. The role that we play is a non-clinical individual support plan that we do with clients based on the matters that they're presenting with. So let's begin with our acknowledgement to country. In the spirit of reconciliation, Hayter Institute of Education acknowledges the traditional custodians of country throughout Australia and their connection to land, sea and community. We recognise Aboriginal and Torres Strait Islander people as the first inhabitants of this nation and the traditional custodians of the land on which we work, live and study. These lands have never been ceded. We express our gratitude for the sharing of this land, our sorrow for the personal, spiritual and cultural costs of that sharing, and hope that we may move forward together in harmony and in the spirit of healing. We pay our respect to all First Nation people and acknowledge elders past, present and emerging, and extend that acknowledgement on behalf of Hayter Institute of Education to anyone who may be First Nation or Torres Strait Island and are listening to this recording. Let's get started. So in an overview of our first part of this 3-part session in this recording for you of a core unit, we're going to have a look briefly at the Australian legal system, human rights and mental illness, codes of ethics and practice for us in the sector, the mental health workers, community sector workers, youth workers, AOD workers, dignity of risk, which means the right to choose self-determination by the clients, duty of care that we must have over children and their mental health as well. And what's the economic agenda that's usually driven by what our government will decide to invest in mental health? So historical context of mental health in Australia, the social context and the myths around mental illness. So if we were in class in real time, we would do an icebreaker, but I want you to do, just take a moment and let's have a look at this particular icebreaker. So when we're in class in real time, we will often spend time just practicing what are some of the techniques and strategies. If we've got a client that arrives at a session and they're fairly heightened, meaning they're not at their baseline, they may be fairly low or flat, or they may be very heightened. And we write down the psychache and those observation skills that we have when we're working with our clients. So box breathing is about breathing in for 4, hold for 4, and then release, and then hold for another 4, and then breathe in for 4. And so we breathe in through the nose for a count of 4, hold your breath for a count of 4. Breathe out for a count of 4, and hold your breath again for a count of 4. So if we need to be able to give our clients a technique and a strategy around this, we can show people that they can do this just by making that mark on their leg. It's nothing that you need to have anything clever, go to a private place. This is something that can help our clients regulate very quickly. But if they're heightened or they're flat, we may start our session by saying, let's just do some breathing for some stress relief today. It's helpful for us as workers before we head into that space as well. So just practice this. This is going to be our icebreaker. I'll send that out for everybody as well. So as workers, we will have a toolkit of resources, things that we find helpful for our clients. We'll be asked in our assessments and in our skills, our role plays, to demonstrate what resources did we give our clients to be able to help them. That might be the mental health wellbeing wheel, that might be a breathing technique. What are some of the strategies that we can work with our clients so that they can have these tools, what I refer to as a worker, as in the meantime. So if a client only comes in and sees us once a week or as part of a program and we're not working individually with them, we need to be able to make sure that we give our clients agency. What can they do when they're not with their support worker? What can they do when they have those moments alone? And so the more tools and resources that we can have for options, there'll be something there that works for that client. There's lots of strategies around that we can apply, like yoga, Tai Chi, breath work, mindfulness, colouring in, activities that we could do when we bring a client in. When you're doing your assessment work, you'll have a combination of both written, and that's your research and your case studies, and your skills, your practitioner skills, you as a worker. So, and that'll be you demonstrating, as it says here, the humanity we share is more important than the mental illness we may not. So what brings us all together when everybody has a mental health? And it's not linear. We can have moments and external things that will place a great deal of pressure on us. And it may be that we can identify what those triggers are. It could be that there's been a psychological injury and that will take a therapeutic framework and can take years to be able to work through that, to build the resilience. So time alone will not heal. However, time with resources and different coping strategies and mechanisms, being able to unpack that with the support and individual care plan will help many people in that recovery state. So what's the legal system in Australia? Both legislation and common law affect the role of mental health services worker. It impacts on us. If we've got a client and they're before the courts, sometimes they're in front of the police, the correctional system. Many people in correctional centres have undiagnosed mental health issues. So it's very important that you understand how to do your work in a legally compliant manner. So rather than through the criminal stream in the courts, we may advocate for a client to be heard under the mental health tribunal, where there's extenuating circumstances. We need to make sure that the rights of our clients, our own health, and in the workplace, that we are not impacting on the psychological injuries for our clients, our peers, and making sure that we are psychologically safe as well. So with the legal and ethical considerations, the Freedom of Information Act, people who have mental health issues have the right to have that information made available. Sometimes to get health records, people have to make an application. That's not easy to do, so you may be walking beside a client to be able to help them with that. The Privacy Act of 1988, the Family Law Act, racial discrimination, disability discrimination, sex discrimination, and age discrimination act. The United Nations Declaration of Human Rights, which is the right for everybody. So you're going to refer to this in your written assessment where you do your research. We're going to apply this when we're doing our skills. So human rights and mental illness is the United Nations General Assembly has principles for the protection of a person with mental illness and the improvement of mental health care. The World Health Organization, often referred to as WHO, has information on mental health and human rights. You can go there and do your research for your own research project, for your written assessment. Just know that if you have a link in your learner's guide or on your slides, that with the cyber attacks that were happening in September 2024, that a lot of those links won't go directly from your device into those pages now. So that means that it could be something that you're watching on your device that is just letting them know that it could be a threat. So go into your own search engine, put those keywords in, and copy and paste if it won't, otherwise pick up those keywords. So for here, you're after the Better Health Victorian Government, and you're looking for stigma, discrimination, and mental illness. So once when people didn't know as much around mental health, there was a lot of stigma about coming forward. It was viewed as a weakness. Right up until the 60s, people were locked away in institutions. It was a cause of embarrassment, a secret, but now that's changed. Now we have things like Mental Health Week. I'm recording this in Mental Health Week in 2024 in October. However, we also have Are You OK Day. We've got Lapse for Life, lots of awareness and education around mental health. Now we view that more in a sophisticated, mature way, emotionally mature way, and it's coming into the workplace more and more. And I think it's being led a great deal by people showing that it isn't a weakness, it's an invisible injury, and that we all have a mental health. There's a video there for us to watch as a resource. There's codes of practice, which I'm going to make sure that you have this resource, the ACWA, the work practice guidelines on how we as community sector workers must conduct ourselves. So while it's not a regulatory body, it is a standard of practice. So you might see in your feedback for some of your written work, well done. You have passed that and met the sector standard. Sector standard refers to this, the ACWA, the Australian Community Workers Association Work Practice Guideline. So we'll give you a copy of that for your resources. It talks about the ethical practice, how we must conduct ourselves in the workplace with our clients, with our peers, the provision of services and support, the equity, access and fairness around that, and the confidentiality in the workplace and how we must conduct ourselves as workers in this space. It is there for our clients, and it's also there to protect us as workers. So there is a regulatory framework, but it's not a regulatory body, because a lot of the work we do is autonomous. It might be in the field. You can have the accidental counsellor, where we can ask people how they are going and then go a little deeper as well. So mental health first aid now is just as common and popular as first aid and CPR. So in the workplace, you'll have ongoing professional development and you'll have a professional standing. So depending on where you are living, in which state or territory, I'm based in Queensland. I sit on Tarrabaland, Bundaland. So in Queensland, I belong to a peak body and have a membership with Queensland Alliance of Mental Health, but I also have international memberships around mental health for child, youth and family as well, because I mostly work in that sector in my roles outside of HADA. So this isn't an activity that we're going to do, but this is something that I want you to do in your own time and reflect. Once you go in and have a look at the ACWA Code of Ethics, I want you to reflect on, is this something that I would do and I feel comfortable with applying in the workplace? So I want you to research that. I want you to go into your copy that you're going to have now as a resource to have a look at both the Code of Ethics and the practice guidelines in this resource that we provide you. If we were in real time, we would do that as a group activity. This is your reflection moment. We're going to talk about reflection journals as well. And these reflection journals are something I've kept one every single day for 29 years as a frontline first responder. Every day I wrote down what I did well and what I could do differently. And then I'll make some notations around what are the things that happened today. I'll put in things like the weather. I'll put in if I'm fatigued. I'll put in if I've hydrated and, drank the right amount of water. What's our self-care? In your assessment, you're going to be asked about what your own self-care plan is, especially when we're working in the spaces around mental health, suicide intervention and prevention, when we're in this space, when we're dealing with some very difficult cases around grief and loss. So this is about your reflection and what are your feelings around how you manage yourself, your own mental health as a worker, and how we sustain that so that we can turn up for work and listen to those stories and still be okay. So we have vicarious trauma. Sometimes it may be their story, our client's story, someone else's story, but it will impact us. I want to remind you that if you feel that there's anything triggering in any of the content that we're doing, anything that you're reading, then you need to be able to contact. We do that in our induction recording for you, but contact Lifeline on 13 11 14. Contact 13 Yarn if you're First Nation. Go to the site, which is interactive, Beyond Blue. If you want to work with young people or you are a younger person, then go to YB Blue, which stands for Youth Blue. There are interactive activities in there. Black Dog is another amazing site for us to be able to go in. They have a mental health check, the K10, which is Kessler's checklist of asking a certain amount of questions in a non-clinical way for some reflection. Now, that is a clinician's role to do a diagnosis, but it's a pretty good way to do a checkup from the neck up. How are we traveling with our mental health? Often we only respond to our physical and we push down those feelings around our mental health. So service provider to service provider, we care for each other and sustainable, but there are professional networks. When we're working with our clients, we need to make sure that we are in a good place as well. The dignity of risk that sits around our clients, it's their right to choose. When we talk about self-determination, that means that there are risks, but the client is the one who weighs those risks up. The dignity of risk is about a balance of the client's own choice and us as workers and our duty of care. There will be moments where we believe at that intake and assessment where we will say to a client, everything that you say here is private and confidential. And the only time I would ever share anything would be if I thought that you were at risk or others were at risk. And that would be around your safety, which is my priority. That is my duty of care. And when we talk about if others are at risk, we are the others, you and I. We are the others. So are our colleagues and peers in the workplace. So when somebody is working with a sector worker and they go and only see their worker once a week or whenever they're booked in to do that, or their GP, know that in the meantime, what do our clients know about how they can get some support and help, and when should they do that? So it should not be hindered by overly cautious caregivers and concerned about their duty of care. If we think that there is potential for harm, then we must report it. We must follow our incident reports. We must report it to our line manager. For this, we have First Access, which is your dashboard. That is your simulated workplace environment. And there's extensive policies and procedures on what are the steps that we must take. Our duty of care means that the responsibility of each person to do everything within their power to ensure a safe and healthy environment. Duty of care and dignity of risk are a very fine balancing act, and you may find yourself caught in that ethical dilemma. The two, however, work together in mental health services. In the Children's Act of 1989, it does specifically address mental disorders, have specific powers to enforce treatment, and have specific safeguards under the Mental Health Act, can be appropriately applied to children. However, when we're looking at a paediatrician, often they will not do a diagnosis until that child is 6, turning 7 years of age. Sometimes these things are wrongly identified as behavioural when really it could be something else. So if you think about the mental health around someone who is neurodivergent, so that's autistic, ADHD or ADD, then it's very difficult to diagnose. So often they will wait before they will bring in a fixed diagnosis, but it'll be around addressing this and keeping an eye on it with your GP, with your client's GP, and talking about that. Sometimes a full scan, blood tests, and that to rule out if there's an iron deficiency or something else. So we look at both the physical and the mental. When we're looking around health, we think holistically. So there are other alternate ways to look after health, but none of them replace the clinical diagnosis, which only a professional can do. However, if a client comes in and says, I have anxiety and depression, then that is where we meet them. We believe them and we acknowledge that, whether that's been diagnosed externally or not. We need to have an understanding and an approach on how we work with people, because everybody has a mental health. Here it reflects on the application of the mental health legislation in younger children. Do they have capacity? And then what is age-appropriate environment, like adolescent mental health as well? So it's a different system that we apply. It's the same as when we're in the court system for young people. Up until the age of 24, a young person is still considered from 12 years to 24 years of age. So there's other developmental issues that are still coming into play there. There could be other disabilities or differing abilities in there, but a diagnosis usually can happen. That psychosocial safety that we can apply, how we work in complex PTSD, which is developmental post-traumatic stress disorder, based on something that they may have been a victim survivor to, if we're working with young people. It could be, when we're working with adults, it is the body's inability to process the trauma, and that's what PTSD is, until we can have that proper trauma-informed practices and the approach which sits around mental health. So no other person or body is authorised by law to make decisions for a patient, and you can give consent or you can refuse with informed consent to treatment. It is absolutely the right of the client to have all that information. You as a worker must make sure that you provide all the information for the client to make that decision, and we need to pitch that at their level of ability to understand. So there's different legislations. You'll be asked to do these in your assessments. These will be areas and questions that you'll need to do with your own research. You are not identified by your illness. If you have a diagnosis, that would be a label. You have an individual story to tell. You have a name, a history, a personality. Staying yourself is part of the battle, which is where we work with that authentic self. For a lot of people, wearing masks is a coping mechanism, but some people have adopted unhealthy coping mechanisms referred to as maladaptive. So they don't meet the needs of the person. Sometimes people will self-medicate or self-harm. In an historical context around the Mental Health Act, in 1811, it was considered madness, bad blood, something that came through that family line. The management was either custodial, physical restraint, isolation and control, mostly because of the stigma and the embarrassment. There was very little emphasis on treatment and staffed by untrained care assistants. It changed. It moved into the late 1800s, where medical superintendents became part of those institutions. The philosophy increasingly became one of humane care, though mostly it was to study and have an understanding. There was overcrowding, often resulted in custodial management going into the prison systems. That still can happen today. In an historical context, mental health care in Australia in 1867, an Act of Parliament sends people with mental illness into an asylum rather than into the prison system. In the 1900s, the separation of mental illness and mental retardation was identified. Male attendants remained untrained because it was mostly around restraint. Now the laws are there to protect people from having restrictive practices, which is cannot medicate, cannot strap down. So it would only be applied, and there's quite a lot of rigor over that space to be able to do something like that. Restraint can also be medicating people to calm them down. It cannot be done because someone makes a decision. It must be done, and proper due process has to be followed. Medical superintendents in the 1900s started to train staff, and then the introduction of female staff was considered. Up until then, all were working with male workers. 1950s to 1980s, it expanded the nursing studies to include mental health in the curriculum of studies. There became specialisation in nursing. Now in the medical sector, you can have a mental health nurse, you can have someone who studies mental health, and you can have someone who can go as far as having a master's in mental health with another degree as well. So around mental health, it's usually done in case management. However, us as workers with the qualifications that we are doing, we only need to have a broad understanding. If we do an individual support plan, then that means that we are working with what the client presents rather than what we determine around that. There could be a story, but we would bring in other professionals, allied health professionals who are trained in mental health to do the diagnosis. And that might mean the GP, that might mean a psychiatrist or a psychologist or an occupational therapist, so that we've got a full wraparound support, a holistic approach for our clients. Us, though, where do we sit in that? We are community non-clinical mental health support workers because everybody has a mental health and we can work with everybody. The specialising on this unit is to give us an understanding on our approach and how we're going to work with our clients when they come in. Your assessment and written work will ask you those questions. What conduct must we apply? What practices and policies? What legislation frames that for us? And then how do we go about doing that work in our skills? In the 1970s and 80s, as they started to close down those institutions where people were locked away, there were smaller units in general hospitals. So in the public system, we have mental health units. We have child and youth mental health sections in a hospital as well, where it's appropriate that young people up until the age of 24 are not treated the same way as adults would. However, it might be that a 24-year-old would have both, where they would have a pediatrician, psychologist, and someone from the youth mental health come over and be part of that in the mental health unit. There was an increase in community-based care, and this is where we sit with our studies, a reduction in length of stay in the inpatient unit. So only the very high risk would have hospital beds. However, now there's programs like Step Up and Step Down, so that if someone is unwell, rather than be admitted into the mental health unit, it could be treated as respite for a period of time and then be able to return home if that care is too great for someone to do on their own. Or we may be working in the community setting, and your qualification, which is CHCMHS001, will frame what that would be like if you've specialised in this area. So a significant number of people were never admitted to hospital, yet are very well managed. And we rely heavily on the community sector and all of us working together in the allied health space. So currently there's a significant number of people never admitted to hospital, very well managed in the community. 1 in 4 young people have evidence that they will experience mental health disorder, and 1 in 5 in adults. So it needs to be the least restrictive, most accessible to mainstream for people because it is so common. There's stigma around it and discrimination, but less so. The more education and awareness under better outcomes, better health. In a social context, often it can be referred to as shame, hopelessness, and isolation. If someone is at risk, we assess that. Helpless, hopeless, and alone is the triaging around suicide intervention and prevention. If we're assessing someone's risk of suicidality, we listen for that in the language. We ask those questions, which is around the very high end of mental health disorder. A lack of understanding by others, often because it is invisible and people hold that internally. There are fewer opportunities for people experiencing mental health disorders. There can be bullying, physical violence and harassment around that, and a lot of self-doubt. So we challenge the stigma around the social context of mental health care, not to label our clients by their mental illness, even if the client identifies that first. Often someone with PTSD must tell the whole story from beginning to end because it is a loop. And so if we interrupt or we ask too many questions while someone is unpacking that story for us, they will go back to the beginning and start the story again, because often someone untreated is defined by what happened to them, defined by the incident, defined by the psychological injury. There's some videos there and resources I want you to watch and reflect on those. The impact economically of mental health of people away from work, people unable to work, and then the cost of mental ill health in Australia each year is about $4,000 per taxpayer and costs the nation more than $60 billion annually. So $4,000 per year around mental health, and yet in some states and territory, that is all the government has put aside for the education of a young person going through their primary and their secondary schooling. So the cost is great. So when we're in that education system, we need to educate around the social emotional well-being as well, not just the physical and the academic knowledge. So the economic agenda is the impact of poor mental health is to invest to save, which is early intervention and prevention. And it is the key to reduce complex, meaning for a very long time and layer upon layer, and the costly interventions of the occasions of services where people seek help. So mental health problems don't affect me. Up to 45% of the population will experience mental health issue. That's a myth. Children don't experience mental health issues. Half of mental health issues show signs before the age of 14. People with mental health problems are violent and unpredictable. The majority of patients are no more likely to be violent as anybody else. Prevention doesn't work. However, we know that higher overall productivity, if we apply a safe and healthy workplace, better educational outcomes, lower crime rates, stronger economies, lower healthcare costs, improved quality of life, increase lifespan, and improve family relationships. So healthy relationships with self and others come into that space of mental health. Myths about mental illness: people with mental health needs cannot keep or tolerate a job. Everyone has mental health. However, there are certain things we can place around that can help us manage those stress loads. And some of those are strategies. So we can have more productivity in the workplace and all people to be able to take their rightful place in the community, regardless of having a mental illness that's been diagnosed or struggling and going through something like a natural disaster, a grief and loss in the family, or some other emotional trigger that has reduced someone's capacity to be able to thrive. Another myth is there's no hope for people with mental illness. Many people will get better and fully recover. It is not a weakness of personality. There are factors that contribute, and they can include biological, so it's genetic, physical, nutrition, injury and brain chemistry, life experiences, how we cope, our capacity to cope, our resilience, our agility, history of abuse, and then family history as well. So in wrapping up session 1, and we're going to take a short break, is the Australian legal system, the human rights of our clients, code of ethics and practices that we apply from in our workplace, mental health workers, rights and responsibilities, the duty of care we have, and the dignity of risk that our clients around self-determination. Having informed consent, making sure that we do provide the information so our clients have information to decide, but they also have the capacity to understand what we are saying. We need to get that consent at the very beginning of any session that we have with the client. Do you understand? Do I have your consent? And we must have that at the beginning of every session that we have with a client, even if you see them every week for 10 years. Just because we have said it once does not mean that stands for today. This is your practice standard. We'll have mandatory reporting if we are concerned. Children and mental health we have covered. The mental health legislation, we need to go to the Mental Health Tribunal, the legislation, and WHO, the World Health Organization. The economic agenda is going to form part of your written assessment, the impact that has and the cost to society. and then the social context and the myths around mental illness, and how over the years we have dedicated more to education and raising awareness. Let's take a short break. Welcome back. Hope you took 5 minutes for yourself, did some box breathing if you needed to. Looking after our mental health while we're studying is equally as important. So we set goals and we take breaks and we do our self-care. This is a particularly difficult unit for some people to be able to work through because some of our clients will come through with some very stressful situations. The scenarios that we are going to be doing will be complex and people will be presenting with mental health issues. And you'll be doing your role plays around 3 different clients and the scenarios around them as well. Let's guide you into that space in a safe way. Look after your own mental health and your own self-care while you're doing your work. So some of the questions around and an overview as we jump into the second part of our session. What are some of the values and principles around the mental health sector? How do we empower patients through making decisions of their own? What are the social justice and advocating for people unable to advocate on their own behalf? And what's the holistic approach around bringing in all those wraparound services, respectful relationships with our clients and with each other, and the self-recovery, knowing that it takes time, knowing that there can be relapses as well, and that things can be triggering and have a setback in recovery. Here I've put in a clip for you on your window of tolerance, how someone is coping. Often that is that hyper arousal when someone presents as really heightened. In my file notes, when I'm writing about that, I might get all the basic details, but my observation will be the client appeared and presented as whatever that mood is. So really heightened, they were agitated, they appeared to be angry, anxious, they were moving quickly around the room. They were feeling like they were over the edge, a bit antsy and defensive. This is all hyper arousal, which is mental health. And then the maybe we can work with them in that learning zone. It's unfamiliar but safe enough, excited and nervous, but a bit uncomfortable, a little buzzed, and heart racing, that is on the way. And then the comfort zone. That's that window of tolerance, our baseline, where we need to be able to get our clients to do that work. We cannot work with the client if they are really heightened or if we meet them in that same space. So if we're feeling a little stressed, we've got to pause and take a moment and do our box breathing, or breathe in through your nose, put your tongue on the roof of your mouth. There's lots of different techniques when you do that. But if you place your tongue on the roof of your mouth and you breathe in through your nose for 4, and then out through your nose again for 4, you will feel that in your diaphragm rather than only here. So in your diaphragm will help you get into your baseline. And I want you to practice some of these techniques. If you're feeling stressed, then use a technique on yourself because you'll be able to do the same with your clients. So bring people back into that window of tolerance, that comfort zone where they feel safe and fully present. We must do the same when we're working with our clients. Otherwise, we may pick up some of the stress that they're experiencing as well. So we also have a learning zone when we've got hypoarousal, where someone is flat and not really communicating, non-committal. So it's unfamiliar, but safe enough, over the edge as well, but activated. So it's apathetic, dissolving, disassociating, to protect, numb, a wall of fog, and I'm not really attached to my body. And that's the state. And we look for these in our observations. The client presented as. The psych 8 was. We'll unpack that a little bit more of how we do that. So I will put down risk, low, medium, or high. Risk of what? Risk of self-harm, harm to others, risk of suicide, any of those factors there that sit around someone's social, emotional well-being. So this is your window of tolerance. In the green zone is the comfort zone, safe and fully present. We need to be there for our clients to meet us there. So if someone is really heightened, know that you're not going to be able to do a lot of that work until they're in that space. And they may come in and that's all you do is help them get in to that comfort zone, that regulated baseline. That is effective. And then showing our clients how to actually do that as well. So with health and mental health, the purpose of health promotion and education is to promote and prevent, to raise awareness for others, to positively influence the health behaviour of individuals and those families who support them, and then disease prevention, to keep them safe and to get in there earlier around making sure that in that toolkit that we have strategies that will prevent and do the early work so it doesn't become a major disorder. So the basic principles is that everyone have the right to have access to these services, that there's fairness and equity, the right to be able to access healthcare and participation as well. So when somebody is working in that space, access means regardless of race and ethnics, regardless of religion, country of origin, gender identities, sexual orientation, abilities and disabilities, spoken languages, ages, everyone, that we walk beside our clients and we stand here with them, that they are safe when they access our services and supports. So historically, citizenship was denied to people with mental illness. However, today, recovery is the paradigm for helping people with mental illness and having mental health treatment. So it's addressing their citizenship needs, taking their rightful place in community. If someone is unwell with a physical illness, we treat that. We might isolate to care for ourselves. We may be admitted into hospital to have that specialist treatment. It is the same with mental health. An holistic approach would mean thinking of many other ways. So we're looking at the health, which includes family, work, stress, environment, historical childhood, emotions and trauma, having an understanding of the big picture. And from that information, a holistic treatment plan is created. So rather than the thing that someone comes in with, I'm feeling really stressed lately, we're going to take them back. But first of all, we're going to connect. We're going to engage so that our clients can establish trust in us, that we're consistent in our approach with professional boundaries. And then as we connect more and people trust us more, they may share their story and we can get to some of those root causes and what else is happening for you. So sometimes we're quick with a solution when someone comes in with a problem, but what else could be going on there? And your engagement is paramount to that. There's a brief video there, a resource for you around what is holistic health. So mental illness is not a choice, but recovery is. So people will recover if they feel it is safe to do so. As a worker, we're going to get them into that safe comfort zone when we work with them. Don't be in a rush to come up with a solution to a problem. Make connection first. That's very powerful. Then you can do the work that you'd like to do. Communicate to develop respectful relationships. Establish that safe environment. You do that with your verbal and your non-verbal. The energy we bring into that space will help someone click with us. Not every worker matches every client. Establish respect, trust, hope and healing, and self-direction. Basic communication strategies around eye contact, looking at someone. So when you do your role plays, your skills section, that don't be reading from a script, even though a script is great to help you prepare and plan. This is about us being able to assess you in readiness to be able to go and work in the sector and have these skills. So the role plays or the skills assessment are not something to just grin and bear. That's an opportunity to get some coaching. So you have 3 attempts with your assessments, with your written work. You have 3 attempts with your skills and practitioners one. Often the camera can make people feel really uncomfortable. But if you're working in that space, then, and you think, well, if I was with a client, I'd probably be okay. I don't think about it, but you need to let go of that. For this qualification, we need to assess you both with your theory, your knowledge, and your skills. So we need to work in a way that prioritizes the person to direct their own recovery. When you're in that space, your written work, reflect on that. How do I do that? And when you're doing your skills component, how can I demonstrate that I've got that connection with someone? If you feel that staring into the camera to record that work is unnerving for you, then don't. Turn on an angle. And even if the person that you're doing your role play with isn't on camera, face them as if they were. But if it says you will do this with another person, you must. It's part of your assessment. To do that is so that we can measure your skills. If there is nobody there and you're anticipating it, it can go any way with the client. We need to put you in those situations to see how you respond to that. So make sure the person that you have as a client is someone who can read the script and gets an understanding and step into that space. If you come into the study sessions, we will connect you with some peers. But if you are doing this in self-directed, structured learning in your own time, you may have someone from work who could do that, or a family member. Just know that you need to simulate a workplace environment of you being the worker and wrapping your head around the scenario. How would I work with that client if this was someone that I was dealing with? We give you the story, but the skills are the things that remain the same. And these are the skills that you must have to be able to engage, establish rapport, build trust, be consistent, have healthy professional boundaries. Self-directed care as adults with cognitive or physical disabilities may need an individual support plan and an individual support worker to assist them to have capacity in that space. Adults with chronic illness need that extra support. Families who have children with medical conditions that require continuous care. And then people who need both regular medical and personal assistance that does not require continuous hospitalisation. This is the space where we work as community sector workers in non-clinical mental health. So some of the programs might be individual support, just the daily, day-to-day living skills. One of the scenarios in our role plays is about someone who has post-traumatic stress disorder from floods. And as you read that story, they cannot yet work with water because it's very triggering around their mental health. They were traumatized and they are still in that recovery. But the day-to-day support that we will have as a community worker might be that you're doing a home visit, and then how we're going to work with that client so that they can progressively try different ways of doing that. So by having a fear of water because it triggers their post-traumatic stress disorder, what are some compromises and some strategies when it comes to something like daily hygiene and bathing? What are ways that we could do that? And sometimes we've got to start very, very small. It might be wet wipes rather than running water. Can't do the dishes because when I turn the tap on, it triggers my post-traumatic stress disorder, my PTSD. So you as a worker may need to be able to work with your client. What would be another way we could do that? What supports are available for that person if they had a physical disability? Then we would work with the same as if they had mental health deficient capacity or diminished. So there's a role play there as a resource for you. But we need to recognise what are the supporting and individual differences. So we need to look at the whole person, the cultural, spiritual, their sexual identity. We need to communicate for respectful relationships, that we can't apply our own views and attitudes or values. We need to consider the client's individual needs, their stages of life, the development and the strategies and strengths that we can apply and build on what they already do have. So we refer to that as asset work or strength-based care rather than deficit, focusing on the thing that they cannot do. And we'll support in activities. So we set realistic goals, and each day that we are working with them, we build on those strengths and those small steps. So the individual needs are about setting goals that are realistic for them and activities to help with an individualized support plan. So how the personal and other support is provided, and how do we communicate these strategies with our clients so they feel safe in those discussions? Be aware of the sentences and statements that we use. How will that be received? There must be safety in our language, safety in our words, and safe storytelling. How we listen, how we believe, how we acknowledge, how we sit in that space. And sometimes there are no words that are shared, quite a long period of time. But that's about helping someone find that window of tolerance and regulate that space. We're there to walk beside our clients at the pace that they are comfortable with. We'll make suggestions, but it is up to the client. We lead by example. Rather than go in flat, we don't meet them there. We're not too up because that can be insensitive, but we need to find our own baseline and present at that. So we need to focus on what's valued and the aspects of the clients, what they want to do, provide support to present a client in the best possible way, encourage our clients to participate, to include them into things that in the community when they're ready and that they have an interest in, and then focus on strengths and interests, abilities and knowledge that's already there, and build upon that capacity building of what it is that's unique about them, and so that it's comfortable and safe rather than pushing people out of that comfort zone until they're ready. So rather than restrictions or a deficit or a negative approach, we'll work on hope, a time where they did feel happy and had hope, and bring that forward into the future. So supporting our clients with their right to mental health care, knowing that there are legal frameworks around an involuntary mental health order, doing some research around that as well. Go to reliable sources, health.gov. Making sure that we have a clear understanding around the confidentiality and respecting the privacy of our clients. I live in a regional town. Often I'll come across people that I'm working with That connection is never about the work that I do. It's meet and greet and hi, how are you? But I've worked in some programs where, because we have a lot of access to private and confidential information, it's been very clear that when we leave that role, that we cannot engage with any client. So it can be very hard for a client where they've shared a lot of private confidential information, but to just smile and be friendly is enough. To talk about what happened to them is not engaged. That would be working outside those professional boundaries. Being really careful about the use of someone's name, even if you de-identify, sometimes the story can be enough to actually tell somebody, I think I know who you're talking about. So we just never discuss anything. Even if it's with another co-worker, don't make the assumption that because they've come in through the door of where you're working, that that is everybody's information, because it is not. It is for the client to decide who gets that information. And we only get informed consent if we have a specific purpose. If we want to refer them to another person, it's why, and not the whole story, only the bits that the client is comfortable with. And we need to say to our client, this is what we're going to talk about. Could this be helpful for you? Then it's up to the client themselves to decide how much they share. But whatever they share with us, that is sacred space. The only time we would share is if there was a risk to safety, theirs or with others. So let's take a break. We're at session 2, and we're about to move into the final part of this unit. It's a lot to absorb. I want you to take some self-care. Walk around and do a stretch if you're doing your assessment work or you're watching this. Take 5 minutes break, and know that it's great for our mental health if we do this in 40-minute blocks. Welcome back, everybody. Quick 5-minute break, and then wrapping up our third part of this unit, which is CHCMHS001, Work with People with Mental Health Issues. So in summary of what we're going to cover are respectful relationships and determining what the mental health needs are at our intake process. We do that with our intentional interviewing, where we gather information. We'll come from a strength-based approach, looking at the needs that our clients say, and then what we might think would be there as well. Empowerment and recovery, or moving towards recovery, and provide support to facilitate that, walking beside our clients and responding to a mental health crisis. What happens if there is a crisis, and what are the steps there? Briefly on some of these slides, because we work in that non-clinical space, there are some summaries around the different types of mental illnesses. It is not for us to diagnose, but to know in general terms what bipolar might be. These are the most presented mental health issues. Depression, which lives in the past of something that has happened. Eating disorders, one of the most common. Obsessive compulsive disorder. Personality disorders. PTSD, which is post-traumatic stress disorder, meaning the trauma has passed, but it's our inability for our body to be able to resolve, come to terms with that, and move into the recovery. So we work in trauma-informed practices to be able to support somebody following a traumatic event. A psychosis is where someone is having delusions or hallucinations. If their medication isn't effective, or they're taking an illicit substance and it's impacting with their medication, where people are maybe self-medicating. Not everybody understands that having a drink to cheer up, if they're using alcohol, alcohol is a depressant. So initially it can lift, but then afterwards it can drop somebody down into that hypo, that flat state. Schizophrenia All of these are diagnosed mental illnesses, not for us, but us to be able to get an understanding of what it is, to learn about them, to be able to have that approach. Anxiety and panic attacks, this is where breath work and those tools. Do some research around what is happening and help your clients with some tools, some non-clinical approaches, and support them in accessing, revisiting their GP, looking at the social emotional well-being, and referring on to different services that can help our clients. So we can't be the only thing that our client relies on. We need to be able to build strength-based and resilience in our clients, but at a pace that they are comfortable to work to. So we'll gather and interpret what that information is that our client presents with, and we'll work together with our client on what an individual support plan. We do that by looking at some goals, not rather than the thing that has happened, even though we acknowledge and we're aware, but what are the things that healing, hope, and recovery might look like in that strength-based? So it's about what's the potential for recovery, your strengths and interests, hobbies, the ability to be able to do something now, even if it isn't quite as much as what it used to be. Knowledge around what's happening for you, and then your capacity to be able to manage that. How much support should we have around someone? And if we think we need more support, then we find out what services are available. Here we outline what the 6 key principles are to strength-based approach in our counselling. Look at those because that will be relevant for you in your assessment. It's also something we're going to be looking at for your skills assessment. Let's go back and have a look at one. Working on strength that they have now or used to and would like to return to. The community as being able to be part of that recovery. Interventions wherein an action should be taken, but it's up to the client to decide what support they need. There should be a collaboration between the client and us and other people who are our wraparound supports based on what the client identifies they would like to. And if you've got suggestions, then we make sure that it's information we share and that we get consent to be able to put that in place. Something to think about. You might hold that knowledge, but our clients might need time to process that. What are the outreach services that can go to the client rather than the client go to them? Often it's non-profit, non-government organisations and voluntary ones. Grassroots level, very much a community responsive approach, likely to be closer to a client's home. They're the preferred mode of intervention, and how can our clients access that for themselves? And all people are able to learn, grow, and change if they have the capacity to do so. So in our assessment, it's what we observe and what capacity a client has now, that we keep our file notes and record those observations. They're our psychic. I observe the client do this. We are going to observe you in your skills and your role play as well. Think about what those micro skills are, and then look at some of these recordings, your resources, and consider how people communicate their psychic. Sometimes when I'm in an assessment, I'll say to a client, how will I know you're sad? What does that look like for you? Because a lot of people find ways to cope, so other people don't know that they're struggling internally. What other supports are around? It might be family, might be carers, and it might be other people in the wider community. So what are some strategies that we can use in that person's life to be able to achieve some goals. If we're talking about the client that was in the flood zone and it was traumatic and they're triggered by water, their trauma is attached to the sound of water, the sight of water. So when we're in that space, what would the client like to return to before this traumatic event happened? They can't go back and change what happened, but what does hope and healing look like in the future? Where would you like to get to so that you felt more confident, not restricted? Provide structures for ensuring that the clients are engaged. And that means walking beside them, connecting the things that interest them, and establishing that relationship, which is based on respect and trust. What would be a short-term, medium-term, and a long-term goal? What is the client's priority of need? How did they present? What would they like to do? Some clients aren't seeing us because they chose to. It's often because someone decided for them. There can be a reluctance there. So we have to overcome some of those barriers initially as well. So an individual plan should be monitored to make sure that it is working and it's effective. We should work to some dates and times to measure that progress and give that positive reinforcement. Celebrate any of those small goals and have room for possible modification in case we need to adjust it because what we originally thought may not work, or we may need to add another support service in there. And provide updates in our file notes and in our case conferencing with our colleagues so that we get some input from others if we feel that we're a little stuck, or to make sure that we're on the right track for our clients. We'll look at an individual plan, an ISP, an individual support plan. You might have an individual plan, or it'll just be called a support plan. These are all templates in your porthole under First Access, your simulated workplace environment. We look at the holistic, the whole wellbeing plan, life skills, social skills, career goals, and personal support. We'll encourage the empowerment towards hope, healing, and recovery. Encourage positive role models and peer group learning so that we aren't reducing and keeping people isolated, left alone with those thoughts that ruminate with no other conversation to bring people out of that darker space. Use appropriate and prompting with positive feedback. Celebrate those small steps together and be encouraging. Strategies that support empowerment and recovery is towards independent learning and thinking, motivation, working with our clients as an individual rather than into a group, and respect. Understand and apply the knowledge that you do have around mental health and issues at hand, and then refer on to other supports that will be more helpful, that go outside of the extent of your role or the scope of your role. We should work collaboratively. We want our clients to, if they moved and relocated away from your postcode, that they would know how to get those supports, even if they make great progress and recovery with you. Later on, they're not always going to stay with us as clients, and we have to prepare for setting goals at the entry, doing our body of work, and then planning for the exit strategy once some of those goals have been implemented and that they are now feeling more engaged, having agency over their own choices and decisions. Finding a voice to talk to their GP if the medication that they're on isn't working, or looking at other factors as well. These are your micro skills. Active listening, positive reinforcement, acknowledging that the client is the expert in their own life, Don't impose our own values or attitudes on the clients. Support and encourage the client to make their own preferences. Their readiness for that is purely based on their mental health and how they are presenting. We need to acknowledge. Collaborate with the client, provide that positive support. Always respect your client and their personal goals. We need to get to understand that individual of our client. What are the things that interest them? And our file notes will reflect that. If we encounter any problems with their plan, then we should take that up to our supervisor. Get that feedback. Know that you're getting the best possible input so that you can provide the best care and plan for your clients. Do some research around that. Be really well organised. If you say you're going to do something, then stick to that. If you're late, disorganised, unpredictable, it will demotivate our clients. It may also set off a trigger for the clients where they're having some of those low self-worth thoughts that they are no longer important to their worker. But when you're there, be fully engaged and present. And your clients have the right to expect that you will be punctual and strongly support their plan at that stage that they're up to. You'll continue to monitor for safety. And if the goals are too big, then we help our clients bring them back. Let's just take one step at a time, rather than I've really got to get to that, setting themselves up to fail. What if we tried this? Let's do this together. Make sure the connection is there and that respect. How do we facilitate that progress? We should be reviewing that regular. Choice of words and body language will be of support and provide feedback. Make sure we do that straight away. Good job. Well done. Last week you couldn't do that. Look at you go. So you did a great job of handling the counter inquiry in the simulated exercise. So in your role play, that is your simulated exercise. When we're working with our clients, we might do practice runs. If the goal is to go walking 30 minutes every day, because we know that that improves somebody's mental health, if they can't go out into society at the moment because of how they're presenting, walking around the backyard, where there's still that safety and security, that could be what it is. And then when venturing out, maybe going down to the end of the street with you and then back again at the pace, knowing that that could actually be quite triggering for our clients. So you might think that going to the beach makes people feel relaxed and comfortable. I know I do. But for our client that's gone through the floods, that could be re-traumatizing and re-injuring them. So we need to be considerate around what would be a great individual plan, what motivates them, builds their esteem, and will increase their confidence. So as we start to make progress, then we'll reduce that support when the client is ready and feels that they can let go, that we introduce those things as well as our exit plan, because we want our clients to stand on their own 2 feet, to be more independent, to be making those decisions, and that letting go of that intensive support, that the times that we catch up and meet with them, maybe after 6 or 12 months, can be reduced to once a fortnight, once a month, once a quarter. But you might check in with phone call or text. There could be a setback and we bring that back once a week for 4 weeks. Then we move to fortnightly, then we move to monthly, and we do that again. A setback can be a relapse or a slip, but we've already built on that foundation. The turnaround and recovery time may be quicker. So it does not mean that they won't have a triggered effect. but it may mean that the recovery from that is quicker than what it was before they first started. So it could take days for somebody to be able to find that center again, but it can move to maybe half a day. And then it might move to only for that moment for an hour. So that can take years to get there, depending on how deep that psychological injury is. When we use statements that are I, it's like I've noticed and I feel concerned, rather than you don't seem to be doing very well. We make sure that we frame that around ourselves rather than you, because it adds a layer of blame or judgment or accusatory or a sense of failure, that we're spotlighting them for the things that maybe they are struggling with, rather than I'm worried about your lack of sleep. I'm thinking that that is impacting and it's draining for you. I'm worried about your nutrition. So respect how the person interprets their own symptoms, and then offering consistent emotional support and understanding that they can count on you, and that your mood when you present each time is very professional and having those boundaries. We're responding to a crisis, it will be 000 or the services that we have. So confidential counselling, crisis support on a telephone such as Lifeline, that happens in that space of in the meantime. What happens, what resources can a client use if they're feeling stressed when they haven't got an appointment with us in between times? We don't want to create a codependent relationship. We want strategies and coping mechanisms for our clients. It might be breath work. It might be I'm going for a walk around the yard. It might be that I'm going to read a book. It might be that I'm going to pet the dog. It might be what are the things that help them find that window of tolerance and that coping space, that baseline where it's calm rather than really heightened, really high or really low. Support the client to express their own identity, yet respond to any crisis. When we're talking about what happened to a client, know that we're re-traumatizing or re-injuring. So when we look at our client, we look at the demographic, are they young or older, depending on are they Gen Y, Gen X, Alpha, if we're doing our early intervention prevention. And then the psychographic, what target group are we working with? That we make sure that we're not leaving open wounds, that we close it off. If we open our session, then we close our session, making sure that we're not leaving somebody with a psych ache, an injury. So I've got some emotional equations here. That's our social emotional well-being. I wanted to put that there so that you could have an understanding around some of the language around that. We want people to be thriving, that we want them to feel that they've got something to contribute, and to find their baseline so that things again can flow and that they have control over the areas that they used to have control over in their lives, and that they're moving forward away from where they are and into where that hope and healing happens. So the key learnings are around mental health in a non-clinical community setting, and how we do that and engage in doing our intake and our assessment and doing our individual plan. And then your assessments will be broken down into both your key learnings and your knowledge, which is in your written work. And then, of course, your skills, which is your role plays, and combining the knowledge and applying that over to the skills. And that's the end of our session for CHCMHS001. So I'll send with you some resources with this. As you're watching this recording, make sure that you reach out to our learner support officers if you need some guidance. You can call us and email us as a learner, being able to get that support and guidance, come into those study sessions, which talks about the unit, and then guide you around the assessment work in the other assessment areas of both the written and the skills component of that. So we've come to the end of this unit. Please reach out, go to your learner's guide, look at the extra resources, read through your slides, because you're going to get a copy of these, and watch this recording back in bite-sized pieces and take the time about every 40 minutes and just give that time back to yourself if you can. Okay. Let's have a look at our assessments that sit with CHCMHS001. So this is around our work with people with mental health issues. So each of these 3 clients come in and they've got their own story. There's something that brings them together that's similar, but it's the story that changes. The very first person that you've got for your case study is a young woman by the name of Jacinta. And mostly the barriers that she's experienced is sitting around her study and then moving into her career. And it hasn't quite worked out the way that she hoped it would. She wasn't able to make enough money, had to move back in with the parents. And while these things aren't necessarily highly stressful, what was happening for this client in this scenario was the loss of hope of a goal that they had hoped would work. And so as they became unwell or more stressed about it, they were unable to come up with some strategies and different ways to come around it. So the role for the skills development, for the role play, is to actually work with Jacinta on what was working for them in the past, to find that time where they were feeling strong and confident, and then how to take that today and move that into the future and create something, either the same thing or a slight variation, to monitor and adjust that if that's what they needed. What I wanted to show you though with this, with your skills around the role play, is that when we're assessing this, here are the things in your micro skills and how you engage and relate and establish trust and build rapport with somebody is going to be assessed. So Jacinta, here it's saying during the role play, I observed the learner, this is for the assessor, communicate with Jacinta in a way that develops and maintains respect, hope, trust, and self-direction. So I want you to reflect on that. What does that look like? Watch some of the resources that we've given you. Let's have a look here on the next one. Okay. So again, going through the role play, what we're looking for is observing those micro skills, the active listening, the paraphrasing. I want you to go into that and look at all 3 clients with the scenario. So when we're assessing, we're observing your ability to engage and work with the client, your listening, your unconditional regard. Read the stories and have a think about what would that be like if I was going through what Jacinta was going through. So the 3 clients, the 3 scenarios is Jacinta with a change of goal, a young guy who had a promising football career, who's had a concussion. They're expecting a good recovery. However, he's got loss of speech, he's socially isolated, He's not quite sure how to move his way through, and he's experiencing some lows around that as well. And then the final person is Ariana. And Ariana went through the floods in Brisbane. And during that time, it was too late to get out of where she was, and 2 of her pets passed. And so the one thing that I noticed with all these 3 clients is they've experienced some grief and loss of, not necessarily about the death or passing, but it's the end of something, a hope or a dream or a goal. A lot of people's identity is attached to how other people perceive them as well. So you as a worker are going to be doing each of these 3 role plays, and someone else is going to play the part of the client who is struggling. So you need to read through all of these, do task number 1, do your quiz, and then task 2, move on to 3 and 4, which will be 3 and 4 will be your skills. So go through your written material, watch the slides, go to your learner's guide, and watch a couple of those extra videos on those micro skills. And I'll make sure that I send that through for you on how to do motivational interviewing, how to be able to ask those questions around active listening, and to share with you another resource that sits around what are those micro skills to be able to help you with this. So that's going to be the end of our session. I've done a brief snapshot on your assessment, but on the skill side for this one rather than on the written side. So CHCMHS001, this is the final session and recording that we're doing around that. So we've done all the key learning and the knowledge questions, and we're just wrapping up on what the role plays and those skills assessment will be. They'll all bring in what you've learned with your resources, what you're going to read, and what you're going to watch in those videos. How am I going to apply that intake and assessment? How am I going to make sure that they each find that window of tolerance, that baseline? And how am I going to listen and ask the questions that's going to help them establish that trust and build rapport, so that we can work on some short-term and maybe some longer-term goals as well, but meet them where they are and just take one step at a time. Okay, so I look forward to seeing you in the study sessions and also in the assessments for the role plays. These ones are done in real time with your assessor. These ones need you to have another person with you who will play Jacinta, play Tony, and play Ariana for you. So I'll sign off.